McLennan, and it's my great pleasure to welcome you to today's patient information session on kidney cancer. In our session today, we have a strong selection of papers focused on better understanding of the unmet needs of those diagnosed with and living with and beyond kidney cancer, and addressing the gaps in the knowledge base. I'd like to take this opportunity to remind you to post questions to our speakers as we move through the session in the chat function, and we'll select questions for live discussion, and our speakers will also have the opportunity to answer any questions within the chat function that haven't been asked in the Q&A. Okay, I'd like to now hand over to my co-chair, Mrs. Athena Alexandridou, and she'll introduce herself and the first speaker. Thank you. Over to you, Athena.
Hello. Hello. Thank you, Sarah. Thank you. As we have a patient session, I would like to say 2 words about VHL, because we are patients with VHL disease, which is a hereditary kidney cancer. And me and my family, from my mother's side, we have all VHL, and my daughter also. We were undiagnosed until 2012, when we meet VHL Alliance, and Joyce Graff and Dr. Iliopoulos try to help us upon our situation, because I cannot understand how my mother, my grandmother, my aunt, my uncle have the same tumors and afterwards died because of kidney metastasis. I suppose we have something hereditary, and we try to give our family history, and only a half Australian doctor take the opportunity to understand that we may have VHL, and he helped us. So we built our small organization, and we managed to do our DNA test in a national institute and our prenatal tests and everything. And we managed to find some doctors, neurosurgeons, ophthalmologists, urologists, oncologists, to build our small team, because it is very essential to have an hierarchy in our surgeries, and to know that we may have, or we have a VHL, in order to do early detection and to know our VHL lesions. We have to give a lot of battles here in Greece. We are happy that VHL patients inspired the community of researchers and doctors, and have so many drugs out of the clinical trials. And Dr. Kailin, that won the Nobel Prize on the 2019 because of the study upon VHL. Now we are happy to be among you. Thanks to IKCC, which we are affiliates, we learn about kidney cancer and the early kidney cancer, which is probably VHL, the most common hereditary early cancer in kidneys. And we are happy that we are alive and we're thriving instead of dying without being diagnosed and without knowing which is our disease and our hereditary cancer. I hope will be an inspiration for you all, and please try to dream big and believe to God and yourself. Now I want to introduce Dana Battle in the session of COVID-19 and financial toxicity in patients with renal cell carcinoma.
I'm Dina Battle with Casey Cure, and I'm pleased to present our data on COVID-19 and financial toxicity in patients with renal cell carcinoma. I have no conflicts of interest to report. Although there's no formal definition, financial toxicity refers to the detrimental effects of the excess financial strain caused by the diagnosis of cancer on the well-being of patients, their families, and society. With continued increases in the cost of cancer treatment, financial toxicity has become an important consideration in cancer care. Studies addressing financial toxicity in individual patients are lacking. Financial toxicity in kidney cancer remains uncharacterized. At the start of the COVID-19 crisis, we conducted an online survey to ascertain patient anxiety level around COVID-19 and implications on financial burden. The survey was developed by Casey Cure with multidisciplinary representation from 2 surgeons, a medical oncologist, a psychologist, and patient advocates. The survey included a total of 45 items. Financial toxicity was measured using the validated cost questionnaire. The survey was broadcast over a period of 3 days to the Casey Cure membership through a patient mailing list and distributed through online social media platforms. Multiple responses from the same patient were prohibited by the system through IP address tracking. 539 patients responded to the survey. Median age was 56 years. Women outnumbered men 58% to 39%. 88% of respondents identified as white or Caucasian. People from over 14 countries took part in the survey, but the population was largely US-based at 87%. 52% of respondents had metastatic disease. 35% had localized disease and were in structured follow-up, and 5% were newly diagnosed and had not yet had surgery. Patients with an income of less than $50,000 US were significantly more anxious about financial hardship than people with a high income, measured at over $100,000. 59% were concerned that their money in savings or retirement assets would not cover the cost of their treatment. Only 8% reported being satisfied with their financial situation. 25% reported being financially stressed. 26% were concerned about losing their job and income. 32% claimed that their cancer treatment has reduced their satisfaction with their present financial situation. 50% don't feel in control of their financial situation. Only 8% were confident about their finances. The majority of patients reported that they expected the pandemic to induce medical, behavioral, psychological, and financial hardship. Only 13% reported not expecting financial hardship to occur as a result of COVID-19. Patients with a higher anxiety about acquiring COVID-19 were significantly more likely to expect medical, behavioral, and psychological hardship. The cost questionnaire uses a range of 10 to 44. Lower scores indicate higher financial toxicity. The median cost score in our cohort of RCC patients was 21.5, which is somewhat lower than previously described cohorts of cancer patients in general, which was at 23. That indicates that the pandemic might be increasing financial anxiety. Interestingly, patients who have been diagnosed with cancer but have not yet had treatment expressed higher anxiety about financial toxicity versus patients already on therapy. This was true for both metastatic patients and patients with localized disease. Patients prior to surgery had one of the lowest scores at 20. Patients with metastatic disease who had not yet started systemic therapy had the lowest cost score of 19.8. It could be that uncertainty related to future costs is a larger driver of financial toxicity, rather than the actual realized cost of treatments for patients. Although oral systemic therapy based on tyrosine kinase inhibitors has one of the highest copays for patients, this was a subgroup of respondents that expected the lowest financial hardship, with a cost score of 23.9. The lower rates of financial concern for patients receiving oral therapy could be due to the fact that these drugs are more commonly used in later line treatment, reflecting a patient population that has more experience with treatment and less uncertainty related to cost. Similar to other studies, factors associated with high financial toxicity included female gender, younger age, lower educational level, and lower income level. Both higher anxiety about acquiring COVID-19 and distress about cancer progression were also associated with higher financial toxicity. Our data highlights significant financial toxicity associated with COVID-19 in patients with RCC. Acknowledging financial hardship and uncertainty related to future costs and providing thorough counseling of cancer patients should be considered. Younger patients, women, and those with a lower income have the highest need of financial advising. Financial toxicity in cancer remains poorly defined, and in kidney cancer, it remains completely uncharacterized. More research is desperately needed to address this important consideration for patients.
Thank you, Dina, for a very, very interesting talk. There are no questions currently showing in the chat function. Athena, do you want to start with questions?
Yes, of course. I have one question. I don't know if you can answer it, if there is a way to answer such question. Is it a simple way or a recommendation how we can reverse this toxic situation?
You know, I think the first thing that we need to do really is to better assess how patients and their families are impacted by cost. And I think we often get caught up in health economics and the cost of treatments versus just the overall cost of a medical crisis. I think we need to better understand the cost of people not being able to go to work, or higher costs of travel and transportation to treatment. All of these things need to be measured, and we really don't have a good handle on it. So I think before we can even start to address it and reverse it, we have to just really do the research and talk to patients and understand how they're being impacted financially.
Dina, I have a follow-up question to that, and I guess it comes from the definition then of financial toxicity. So the definition of financial toxicity as it currently exists, I presume then, is very much just focused on the cost of treatment and doesn't take into account the dimensions that you've just flagged, or does it include work and ability to work?
It does. It includes all those things. But I think most of the time when we have discussions about it, at a conference or, among doctors, the first thing that's often brought up is treatment costs. This just came up recently during a discussion about adjuvant treatment. Everyone is always thinking about the cost of the treatment itself. But the actual definition is much broader, and to be honest, hasn't been as clearly defined as it needs to be. But the cost questionnaire, which is the only validated questionnaire we have to measure financial toxicity, looks at all factors. It looks at how people feel about their financial situation. Will they have to spend through their retirement savings to pay for treatment? Will they be able to keep their jobs? Will they lose their income? All those things are sort of part of that questionnaire. So I think it's the best measurement and tool we have right now, but it really hasn't been used as widely as it needs to be. And again, I think we aren't having the discussions in the way that we need to with patients to have a clear picture of what it looks like.
When do you think those discussions are best had within the patient journey then, to include the patient and make them the most informed decisions and judgments?
Yeah, I think that's such a good question. And actually, I was just thinking about that as we were going through the slides. I think we will see, if we were to ask patients if we could survey them at different points throughout their treatment, I think we probably would see quite a bit of variation in terms of that anxiety level and uncertainty they feel about costs. And I think that would help us better define those touch points of how we could counsel and communicate with patients to help ease some of that anxiety. But I think I think we have a challenge as a society to think about how we can reduce costs in all ways, not just in treatment prices, but in, can we make it easier for people to get to their treatment? Can we make sure that they can keep working while they're on treatment? Can we, how can we support them in so many different ways while they're dealing with their disease?
Thank you. That's a really nice answer to my questions. Athena, do you have any more questions for Dina?
I think that we have to do more research in order to find out what we have to do and what we have not to do. And certainly we have a long way to go.
I think that sums it up nicely, to really just say we're just opening this discussion. Sadly, it's something we should have a much better handle on, a much better understanding of. And my hope is that we can all work together to better understand and define this problem within the kidney cancer population, and then work all together to find better ways to address it.
That's perfect. Say thank you to Dina, and Athena, can we move to our next speaker, please?
Thank you.
Yes, we have to go now to Annie Wilson and World Kidney Cancer Day, initial results for the World Kidney Cancer Day 2021.
Hello, my name is Anne Wilson, and I am a director on the board of the International Kidney Cancer Coalition, and I am the project lead for World Kidney Cancer Day. It's my pleasure to present to you some very early outcomes of our 2021 campaign. So we decided in 2021 to focus our campaign on the mental health of those with a diagnosis with kidney cancer. The theme was based on the outcomes of our Global Patients Survey of 2018, which indicated that 96% of those who responded indicated an experience of a range of psychosocial issues. So on the 17th of June 2021, we held our 5th World Kidney Cancer Day around the theme of We Need to Talk About How We're Feeling. 48 IKCC affiliate organisations around the world encouraged their kidney cancer community to create their own personalised psychosocial wellbeing report. The report was done via online survey and was created in 14 languages. 9 multiple choice questions focusing on psychosocial wellbeing were asked, and the data from those questions was anonymised. We collected data on gender, country, year of birth, kidney cancer type, year of diagnosis, and current cancer status. Respondents on completion were encouraged to share their personalised psychosocial wellbeing report with family, friends, and healthcare professionals. So given the campaign only occurred several weeks ago, we haven't got all of our data in, but on putting this presentation together, this data is from 538 reported completed surveys and 381 analysed reports. So 72% of global respondents reported clear cell renal carcinoma as their kidney cancer type. 43% were male respondents, 57 female respondents, with their cancer status. 29% reported that they were under surveillance, active surveillance. 31% reported locally advanced metastatic disease. And in the interests of time, I'm not going through all the questions, but I wanted to give you an indication of some of those major stats that are available in a much more complete report once all our data has been compiled and has come in. So in question 1, we asked, when you think about your kidney cancer, which of the following best describes you? So 14% of our respondents say that they feel overwhelmed, which is unsurprising. 31% indicated cancer sometimes causes anxiety, but they try not to let it worry them. And 25% maintain that they feel confident in their medical care and their ability to cope, so that they mostly managed their anxiety and how they were feeling. Question 3 talks about it as being very common for kidney cancer patients to worry about their cancer coming back, and how would you describe your fear of reoccurrence? So we weren't surprised that 35% reported that fear of recurrence is an issue. 10% reported that they didn't think it was a major concern. 25% said I worry about it a few times a month and it can make me feel anxious or depressed, which is, pretty understandable under the circumstances. Thinking about your life now and in the future, which of the following best describes you? So 49% claimed they know they need to stay positive. It's not easy, but they are trying and hope that it doesn't get them down and doesn't lead them to feel depressed, which is really important, and that's a really good stat. It doesn't mean that we don't need to do more in that area, but that was a really interesting outcome. Question 5 asked, who do you find it most helpful to talk to about how your kidney cancer is making you feel? And this is a really interesting question because only 16% indicated that it was helpful to talk to their doctor, oncology team, or cancer care professional about how their cancer is making them feel. And that's an issue. 32%, on the other hand, said that they prefer to talk to their spouse, partner, close family and friends. We need to do something about people feeling comfortable to talk to their health professional, and the answers to all of these questions, once they're going to be properly analysed, will give the IKCC and our project team an opportunity to look at what additional resources need to be developed, maybe what educational opportunities need to be considered, and what are the implications for patients if they don't feel they can talk to their healthcare professional about how they're feeling. Also, having healthcare professionals be able to think about some signs that a person isn't coping with their cancer diagnosis or their kidney cancer diagnosis is really important. So this is a critical question for us when looking at mental health. When you think about talking to others about how your kidney cancer is making you feel, which of the following describes you? So the majority find it difficult to talk to others about their kidney cancer. They feel needy, they feel that they're a burden, they don't want to be a burden on others, and they just simply feel uncomfortable about discussing their emotions. So we need to look at how we can assist in that, maybe providing a guide for those diagnosed, also for families, friends and carers. How can they help? Since being diagnosed with kidney cancer, have your sleep pattern changed significantly? So we all know the importance of sleep to good health, to the way we function, to the way we cope on a day-to-day basis. 33% said their sleep patterns were generally as they were before diagnosis. However, we had 24% indicating that they sleep less than they used to, and sometimes they lie awake for hours at night. Now, that could be for a whole range of reasons, but that's an area that we think we need to look into to see, what can we do to help people in this situation? In a typical week, roughly, how much physical activity do you do, including walking? In 2020, our IKCC message was that we need to talk about physical activity. And so it's kind of pleasing for us to see that 52% say they were doing more than 2.5 hours of physical activity, including walking, a week. And that's a pretty good result. But that does mean that we've got 48% that aren't necessarily doing that much. We recognise that there are limitations on some people with kidney cancer, and obviously we encourage all forms of gentle or even passive exercise as being a good thing. Finally, question 9 looked at having kidney cancer can change your relationships with family and close friends. Which of these best describes you? And 39% reported that the stress and uncertainty of their cancer had taken a toll on their relationships with family and close friends. They don't feel as close, as some have consciously distanced themselves because they feel isolated, they feel upset, they feel anxious, and they feel stressed. And so this is all about us understanding this period of isolation that people have where they feel they can't tell anybody how they feel, they don't want to be a burden, and we need to develop ways in which we can support our kidney cancer community to be able to not have that sense of isolation and not necessarily have their diagnosis impact their relationships as much as it obviously does. So there's a lot of room for movement there, and I think there are a lot of issues there that we can unpack. Finally, I would like to acknowledge everybody, all our sponsors and corporate partners who make it possible for us to mount a global awareness campaign about kidney cancer each year. So on behalf of all of us, thank you, and our talented team for your ongoing support of our really important work. Thank you and goodbye.
Thank you, Anne, for an incredibly interesting presentation. I'll hand over, first of all, to Athena for her questions. Athena, there are no questions currently showing in the chat.
Annie, this was very, very nice to see how they respond. And I hope we have many responses from Greece also. It is the first time that the Greek patients with kidney cancer try to do psychological report because we have many problems in Greece. Speaking about kidney cancer specific, we rarely hear kidney cancer patients to speak, and this was a great opportunity. And please share with us, if you can, what is that most revealed out of the Q&A of this year. What do you think it was the hot point?
Well, that's a really difficult question for you. It's a good question. Look, I think that the issue is that when people with kidney cancer or diagnosis of kidney cancer feel isolated and feel that there isn't anyone that really understands them and they can't talk to their health professionals. I think the health professional question was an important one for us because it has, there are implications there for things that I think we're able to do. And it's only by understanding what the needs of patients are and bringing our patients and our clinicians together to understand how, you know, they can better understand their patients. And I believe there is a willingness that area will improve. So I don't know that I can really highlight one area, but what we do know is that people do need to talk about how they're feeling, and we need to work on facilitating that in as many ways as possible so that people feel that they're not alone, that they feel that they're able to cope easier. I mean, it's a dreadful diagnosis, and so I think all of the responses would have indicated, and it touches to financial toxicity as well, because there are so many other things going on in patients' lives at the same time as feeling disempowered, as if their world has been turned upside down. So there's a lot of work to do to impact mental health and help people feel better about themselves during these dreadfully difficult times for them. So I don't know that I can really answer your question with one answer, but that's my feeling from my professional background, which is social work.
Thank you, Anne. I think you've articulated that really well and really highlighted the work that still needs to happen around mental health and the recognition of this. I'd like to say thank you again, and in the interest of time, I'm going to close this discussion, and I would like to say thank you and move to introducing our next speaker, Mr. Adriano Becerra, who is the recipient of the Cecile and Kenyana IKCC Scholarship for 2020. Thank you.
Hello. First of all, I would like to thank for the opportunity and for the invitation. Today I am PhD student at AC Camargo Cancer Center in Brazil, and I have worked with patient-derived xenographic model to study the biology of kidney cancer. Today I'm going to present the same results about my project. So the main objective of my project is establish a platform for study in kidney cancer based on a PDX model. The samples used in my project are obtained from patients at AC Camargo and are implanted in renal capsule in immunodeficient animals. The samples obtained from the tumor growth in the animals are used for morphological and genetic characterization. Today we have 64 samples collected and 16 cases with PDX established. As first results, we can see the step-by-step of the standardization of the surgical technique used for orthotopic implant, and here we can see the 4 subcapsular tumor fragment, and here we have the description of the collected case. So we have patients with all subtypes, patients with high staging, and patients with how grade collected and implanted in immunodeficient animals. In first moment, we did the genome sequencing in the first 3 cases, and we can see that PDX tumors preserve genetic change formed in the patient's tumors. The first case used for genetic characterization was papillary 2 RCC, and for this case we looked at 2 alterations in ARID1A in patient tumors and PDX tumors. The second case used for genetic characterization was clear cell renal cell carcinoma, and for this case we looked at the alterations in VHL, PBRM1, KDM5C between patient's tumors and PDX tumors. And third case used for characterization with genome sequencing, we used the clear cell renal cell carcinoma, and for this case we looked at the 4 alterations in BAP1, CDKN2A, and 2 alterations in TP53 between patient's tumors and PDX tumors. And here we can see the morphological characterization by immunohistochemistry between patient's tumors and PDX tumors. Here we can see the characterization for clear cell renal cell carcinoma, papillary 1 and papillary 2. In conclusion, the orthotopic patient derivation model represents an adequate tool for the study of tumor biology because this model preserves the morphological and genetic characterization of the primary tumors in immunodeficient animals. As next steps, I want to finalize the morphological and genetic characterization of the cases, and I want to start drugs testing based on the genetic change obtained in our cases. So thank you for invite and thank you for opportunity.
A fascinating presentation. I just wondered, we have no questions in the chat, but a really brief question to you. You talk about taking this tool into drug testing as the next part that you're moving towards. Could you just give me a bit more detail about that, please? What does this look like to the psychologist in the room?
Could you please?
Sorry, can you repeat, please?
I was just wondering what the drug testing phase looked like that you talked about next.
Okay, today we have finalize the characterization in our case, and based in genetic change, we selected the drugs for testing in the PDX.
We don't have targets yet.
Okay, that's brilliant. Thank you, and thank you again for a very interesting talk. Can I move now to introduce our next speaker, Dr. Elshad Hassanov, please?
Hello everyone, this is Elshad Hassanov. I'm a medical oncology fellow at MD Anderson Cancer Center. Before starting my presentation, I want to thank the organizing committee and the chairs of this session for the invitation and for giving us the opportunity to talk about our recent study of renal cell carcinoma brain metastasis interdisciplinary consensus management survey. I have no conflict of interest to report. Brain metastasis is known as a poor prognostic feature in all solid tumors, including metastatic renal cell carcinoma. Based on different retrospective and epidemiologic studies, 8 to 14% of renal cell carcinoma patients develop brain metastasis. In the recent years, with the development of immunotherapy, there has been a revolution in the systemic treatment of renal cell carcinoma. However, treating the patients with brain metastasis is challenging. In fact, in a phase 2 study of nivolumab on patients with active untreated brain metastasis, the intracranial response rate was reported to be 11%, and the extracranial response rate in that study was 21%. Therefore, CNS-targeted therapies with stereotactic radiosurgery, whole brain radiation treatment, or surgical resection are the main modalities for the treatment. Now, given the multidisciplinary nature of treating this challenging manifestation of the renal cell carcinoma, it's important to develop a multidisciplinary consensus on surveillance, diagnosis, and treatment approach. Therefore, we decided to do this survey study with the goal of developing interdisciplinary consensus on the management of renal cell carcinoma brain metastasis. First, through the network of the International Kidney Cancer Coalition, a multidisciplinary working group was formed. An international panel of experts with extensive experience in the treatment of renal cell carcinoma brain metastasis was invited to summarize the existing literature and also outline the dilemma related to each field. Next, based on the suggested list of questions and the challenge of the field, a survey was formed and distributed to a larger panel of experts. 36 experts from 6 countries and 26 institutions participated in the survey and answered the questions from February to May 2021. And here in this pie chart, we are seeing the distribution of the experts based on their area of specialty. The survey had 7 sections, including questions about the screening and diagnosis, management of single or multiple brain metastasis, periprocedural considerations prior to radiation treatment or surgical resection, systemic treatment options for the renal cell carcinoma brain metastasis, and the role of the cytoreductive nephrectomy in patients with brain metastasis. Today in this presentation, with the available time, I will be able to highlight only the major findings from the survey. Let's start with screening and diagnosis. It's important to highlight that the screening recommendations for a patient with localized and metastatic renal cell carcinoma is different. For example, if the patient was diagnosed with localized renal cell carcinoma without any evidence of metastatic disease, 58% of the experts recommended obtaining MRI brain if the patient has neurological symptoms. Next, if the patient underwent nephrectomy for the localized disease, 88% of the experts recommended obtaining a brain MRI, again, only if the patient develops neurological symptoms. Regarding the screening of brain metastasis in a patient with metastatic renal cell carcinoma, 58% of the experts recommended obtaining an MRI brain at the time of diagnosis, even if there are no neurological symptoms. If no brain metastasis identified at baseline, 59% recommended obtaining MRI brain at later restaging scans, only if patient develops neurological symptoms. Lastly, if the patient had a baseline brain metastasis and treated with CNS-targeted therapy, 80% of the expert panel recommended obtaining MRI brain every 2 to 4 months in the first year and every 3 to 6 months in the second year. Now I'm going to summarize the proposed algorithm for the management of renal cell carcinoma single brain metastasis that was built based on the survey answers and core group discussions. Before going into the details, it's important to highlight that the algorithm is intended to provide a general framework of treatment options, and each patient should be approached in a multidisciplinary fashion. And during this evaluation, it's essential to outline the key clinical features, location, size, symptoms related to the brain metastasis, and also the patient's overall performance status, the volume of systemic disease, and the life expectancy, which are the important considerations for treatment planning. Let's start with a small brain metastasis of less than 5 millimeters. The key question for such a small lesion is whether it's located in an eloquent area of the brain, such as the motor or sensory cortices, visual center, speech center, or internal capsule, the basal ganglia, hypothalamus, or brainstem. If the answer is yes, then in that case, it's better to start with the radiation treatment earlier to prevent future neurological dysfunction. However, if the lesion is not located in an eloquent area, 45% of the experts recommended stereotactic radiosurgery and 35% recommended short-term follow-up with or without systemic treatment. Next, if the patient has 5 to 10 millimeter lesion, SRS is recommended by the majority of the panel, as you can see the percentage from 2 different questions. For a lesion with 1 to 3 centimeter, it's important to define if there are related neurological symptoms, edema, or mass effect. Having these features suggests that the patient may get more benefit from urgent surgical intervention. Therefore, 57% of the expert panel recommended surgical resection, followed by adjuvant stereotactic radiosurgery to the surgical bed if the patient is a surgical candidate. And for a patient who is not a surgical candidate, SRS remains as an option of the treatment. Now, if the patient with brain metastasis of 1 to 3 centimeter, if asymptomatic, then 76% of the expert panel recommended SRS alone. For larger lesions, such as about 3 centimeter, if the patient is surgical candidate, then in that case, surgery followed by fractionated stereotactic radiotherapy or stereotactic radiosurgery is recommended. Now, if the patient is not a surgical candidate, due to the large size of the mass, fractionated stereotactic radiotherapy or whole brain radiation treatment is an option. In this algorithm that was developed for the management of multiple brain metastases, I will highlight the key responses from the survey. For a patient with asymptomatic multiple brain metastases, including single brain lesion more than 3 centimeter, 50% of the expert panel recommended performing surgery on the dominant lesion, and followed by adjuvant radiation treatment to the surgical bed and to the remaining lesions, up to 8 to 10 metastases in total. And for a patient with multiple brain metastasis and single symptomatic brain lesion more than 3 centimeter, 56% recommended performing surgery on the symptomatic dominant lesion, even if there are more than 10 lesions. Now, for the patients who has more than 10 brain metastases, whole brain radiation treatment is the common approach. However, in select cases of low volume brain metastasis, good performance status, limited extracranial disease, and more than 6 to 12 months of life expectancy, 63% of the panel would still consider SRS if there were more than 10 metastases. In this presentation, I summarized the key recommendations from our survey study. The full report of findings will be published along with the manuscript. Here we proposed an algorithm for the clinical management of renal cell carcinoma patients with brain metastasis, which suggests that the surgical resection and the radiation treatment are the main modalities of the therapy. And most importantly, multidisciplinary assessment is a crucial component of the approach for optimizing the benefit for individual patients. This study generated clinically applicable and practical results by the true teamwork of experts from 26 institutions, and therefore I would really like to thank to the expert panel of the IKCC Brain Metastasis Task Force, the experts who participated in the survey, and also the core group at MD Anderson who helped to develop the algorithms. I also would like to express my special thanks of gratitude to the MD Anderson Fellowship Program, the IKCC leadership, and my mentor, Dr. Eric Jonas, who gave me this golden opportunity to work on this wonderful project on the renal cell carcinoma brain metastasis with an international team of experts. Thank you for your attention. I will be happy to take any questions.
Thank you, Dr. Hasanoff, and thank you for a very interesting presentation. We have one question from the audience, which I'm going to make time for, which is, at what points in your decision tree do the patient's values and preferences play the largest role?
So I think it really depends on the modalities and the potential complications related to each treatment option. Let's say if the patient has recommended to have the SRS versus whole brain radiation treatment or versus surgery, each of these modalities has different risks. And as you can see in certain in algorithms, all of those options were potentially be chosen. And I think in that case, it's important to have the conversation in detail with the patient to understand their preference and then expectations from the treatment. And then based on that, I think this should be a teamwork to decide what should be the best strategy for treating that particular patient's brain metastasis.
Thank you, an excellent answer. And if anyone has any further questions for Dr. Hasanoff, can they please post them within the chat, and then we can continue to take them. I'd like to hand over now to our final speaker of today, Dr. Jenny Aragon-Ching. Thank you.
Hi, my name is Jeannie Aragon-Ching from the Nova Shore Cancer Institute. It's a great pleasure for me to be joining you today, and I will be discussing regarding metastatic renal cell carcinoma trials, balancing efficacy and quality of life. These are my disclosures. Session objectives for today would be to understand the results of key clinical trials for first-line metastatic RCC use, describe the side effect profiles, as well as discuss the patient-reported outcomes associated with these studies. This is the evolving treatment landscape of metastatic RCC in the past decade. And notice that there are 3 major treatment pathways that we use for kidney cancer drugs. One of them involves the use of mTOR, pathway inhibition. Another is our vascular endothelial growth factor, or tyrosine kinase inhibition, and this addresses angiogenesis, as well as the use of checkpoint inhibitors. Now, understanding the side effects of these drugs often involves understanding the mechanism of action. So, for instance, common toxicities associated with VEGF and TKI inhibitors often involves vascular side effects, including hypertension, bleeding, clotting, proteinuria, and the hand-foot skin syndrome that you see in the pictures here ranges in severity from the mild to the severe. Now, some toxicities, including diarrhea or lab abnormalities, have clear overlap with other drugs, including IO inhibitors. And checkpoint inhibitors can yield autoimmune side effects or symptoms. And one of the inherent challenges with the use of these drugs is that we cannot predict who will or will not develop the side effects. And any organ is subject to toxicity. So if it involves the skin, we get dermatitis. If it involves the GI tract, colitis, hepatitis, or other organs like pneumonitis or endocrinopathies, hematologic, or even neurologic symptoms. So this is a snapshot of the results from first-line metastatic RCC trials. All of them were positive, but they had different primary endpoints. So, for instance, Cabosun was the only phase 2 trial, and it used progression-free survival, or PFS, as a primary endpoint, compared to sunitinib, which has been the de facto comparator arm for all of these trials. So PFS was also the primary endpoint for CLEAR, as well as CheckMate 9ER. Whereas overall survival in the intermediate and poor risk population was used in the CheckMate 214, and overall survival in the PD-L1 population of patients in JAVELIN for avelumab and axitinib. Pembrolizumab and axitinib in the Keynote 426 use a combination, the dual primary endpoint of PFS and OS. And we see here that the responses incrementally increase with dual or combination therapy. So in the cabozantinib, in the Cabosun trial, we see responses in the 33% range, all the way to 71% with lenvatinib and pembrolizumab. Now, with efficacy comes toxicity. And while cross-comparison between trials should not be done, I tabulated here some of the more common side effects that patients can feel, including fatigue, hand-foot syndrome, nausea, or diarrhea. And we can see from these tables that they may not always be trivial. And in fact, treatment-related adverse events leading to discontinuation of treatment occurred in about 20% or more of patients in some of these trials. Therefore, it's very important for us to analyze the quality of life and patient-reported outcome measures. And as listed here, these are all the validated tools. So for instance, FACT-G looks at the physical, social, family, emotional, functional well-being of patients. On the other hand, some of these other tools like European Quality of Life, 5D or 5-dimension, 3-level system, looks at mobility, self-care, usual activities, pain and discomfort, and even anxiety and depression. And again, there are some tools that are more kidney cancer specific in terms of cancer-related symptoms as listed here. And this just highlights some of the other tools that have been validated. And I want to just point out and show you all that these are the questionnaires that patients get asked. Whether or not they have lack of energy, if they have pain, if they're losing weight or bone pain, shortness of breath or coughing, and they are to answer whether it occurs not at all or very much in the past 7 days. And this was the aforementioned 5D3L system, and some of them have a visual analog scale as well. So I want to point out the quality-adjusted time without symptoms of disease or toxicity of treatment, the Q-TWIST, that was looked at in the Cabo-Sun trial. And in here, as the name implies, some patients may enjoy a good time before disease progression, but if they develop grade 3 or 4 toxicity, then it can severely impact their quality of life. And therefore, Q-TWIST was found to be longer with cabozantinib use in this trial compared to sunitinib by an order of 24 up to 137 days. Similarly, other PROs or PRO measurements, for instance, in the Checkmate 9ER, as shown in this graph here, was an improvement in the comparator arm of nivolumab and cabozantinib compared to sunitinib in all of the different scales that they measured. However, the PROs in clear, and recall that this was lenvatinib and pembrolizumab, while a lot of the parameters, including fatigue, nausea and vomiting, pain and dyspnea, were all in favor of lenvatinib and pembrolizumab, some were slightly in favor of sunitinib, including diarrhea or financial difficulties. Reassuringly, the physical functioning score was no different between the two arms. And if we look at the Keynote 426 PROs, we are seeing similar findings with Pembro-Axi. Compared to sunitinib, there was little change from baseline over time. Well, all of these trials use different tools and parameters to measure the PROs. We can see here, this is a presentation from Dr. Apollo at ASCO, that CLEAR and Keynote 426 showed very similar PRO tools compared to sunitinib, whereas the Checkmate 9ER and Checkmate 214 did show some improvement over sunitinib in the parameters or health-related quality of life tools that they tested it for. Therefore, it's very important for us to balance efficacy with toxicity. And what are the efficacy measures? These are the progression-free survival, overall survival, and responses that are typically the primary endpoints of the studies. So how do we mitigate toxicity? So understanding toxicities and continuation of supportive care measures would be very important. Education and early detection, especially with the use of IO drugs, is very important as well, so that we may be able to reverse the side effects early. Now, for patients on immunotherapy, this is also an important point to consider. What is the duration of treatment? Since a lot of the studies have different mandates on the duration of therapy. For instance, in the Checkmate 214 trial, patients were allowed to continue with nivolumab for as long as there was no excess toxicity and as long as there was benefit. Whereas in Checkmate 9ER, there was a ceiling to the nivolumab treatment at 2 years, and cabozantinib was allowed to continue. Therefore, it is very important to have that discussion with patients, especially those who have achieved good complete response, because it's not always easy also to mandate stopping when they have achieved a good response. In conclusion, treatment of metastatic RCC has rapidly evolved in the last decade, and while treatments are very effective, they are not always without toxicities. Therefore, balancing toxicities and side effects with quality of life and time off treatment would be very important parameters to achieve. And with that, I thank you all for your attention.
Thank you, and thank you for a really interesting presentation. I listened to you speak about the heterogeneity in endpoints and in health-related quality of life measures within clinical trials. And I guess my question to you, Jeannie, would be, have patients been involved in selecting health-related quality of life measures within trials or informing which ones would be most appropriate?
Yes, absolutely, Sarah. And it is very important in all of the clinical trials that patients are engaged and involved, because ultimately these are trials that would benefit them, and they're the ones that would have most gains in terms of these trials. So that's a very important aspect when designing clinical trials, as well as engaging the patients and enrolling them and accruing them.
Thank you. And we've got one question from the audience before we close. Rachel says, Dr. Argan-Ching, wonderful talk and fascinating analysis. Checkmate 9 ER allowed dose reduction. Would that be a confounder?
Yes, and I think, at the end of the day, we always want to understand, how much dose reductions, interruptions would affect the outcomes of the studies. Although I would say that 9ER is, at the end of the day, again, it's a positive trial. So despite the potential dose interruptions and dose reductions, I think, patients in the end did benefit still with the IO-TKI combination.
Okay, thank you. I'd like to say a really big thank you to all of our speakers today for a fascinating set of presentations and a good, strong discussion. Athena, can I hand to you to close our session, please?
Yes, thank you so much. You were all so interesting, and I thank you as a patient for focusing in kidney cancer for body and psychological aspects. And I think we have a long way to go all together. We are very optimistic having you all in our side.
Thank you, and goodbye.